Thank you. Good afternoon, everybody, or early or late morning, depending on where you're listening in from. Today we're going to talk about the use of the MMPI-2-RF in trauma and stressor-related disorders. First, we'll spend some time talking about what constitutes a trauma-related condition, including post-traumatic stress disorder. And then the focus of the webinar was primarily beyond the practical considerations and the use of the MMPI-2-RF in assessing these conditions, or more generally, assessing individuals who have been exposed to a stressful or traumatic life event. We'll address how the MMPI-2-RF can help understand better the individual's approach to the assessment process, and in particular the role of validity scales in defining the individual's engagement in that process, and later their engagement in treatment focused on trauma conditions. Also, we'll talk about how the MMPI-2-RF can support a diagnosis of a trauma-related condition and implications for the treatment of those conditions, that is, how readily someone is going to respond to specific types of interventions that are used in trauma-related conditions. And finally, we'll finish up with a case illustration that will kind of flesh out a bit some of the things we've talked about earlier in the webinar. I will hopefully be able to leave some time for questions, and we'll address those questions at the end of the webinar. So without further ado, let's get into our material. What is the impact of life events? We know that there's a range of aversive experiences that can lead to emotional disruption and, in some cases, a psychiatric condition. And this range of events, in some ways it's defined by DSM-5, but there's actually a broad range of events that falls within that definition, and that includes interpersonal violence, sexual maltreatment or assault, combat, so soldiers or troops that are exposed to combat situations have a much higher rate of PTSD and trauma-related conditions than individuals in the general population. And as an aside, that's really the population that we know most about in terms of any empirical research that's been conducted. Industrial accidents, motor vehicle accidents, bullying, harassment in the workplace, and even the sudden death of a loved one, if it's accidental or violent, can be considered a traumatic event and lead to emotional disruption that's persistent in an individual's life. So some of the disorders that are subsumed within the DSM include adjustment disorders, the acute stress disorder, which is all of the symptoms of post-traumatic stress disorder, but that have not persisted for longer than 30 days, and then PTSD, which is the re-experiencing, avoidance, and so forth, that symptoms that persist for longer than 30 days after the event occurred, or that manifest themselves and maintain and are present for a 30-day period at some point after the sentinel event. One thing to bear in mind, and I think it's somewhat interesting in that DSM-5 does not usually identify a causal factor that's included in the diagnostic criteria, but with trauma-related disorders, this is it does specify that a certain class of events will that occur at time one will lead to emotional disturbance at some later point, either immediately afterwards or in delayed PTSD at some point later. And it is thought that that event directly causes the emotional disturbance. So in a sense, the causal factor is included in the diagnosis, and we really, other than the substance use disorders, we really don't think of causal factors when we consider diagnoses. So this webinar is really focused on the use of the MMPI-2-RF and assessment of trauma-related conditions. And the question always arises, why should we use a broadband measure such as the MMPI-2-RF when we evaluate individuals either prior to arriving at a formal diagnosis or when they enter treatment for a trauma-related condition? Well, there are a couple of factors which I think are fairly significant and important and really gives the clinician a leg up in terms of better understanding the individual and how they are responding to the life event that they've experienced. The MMPI-2-RF provides an objective means of assessing emotional disturbance in response to the life event. And it will support the diagnostic formulation. Again, it is not a diagnostic instrument per se, but what it does is it provides another source of information that in a multi-method approach will support our diagnostic hypotheses if we believe that it's a trauma-related condition and that it's post-traumatic stress disorder, and there are aspects of the MMPI-2-RF that either are supportive or in some cases not supportive of that hypothesis. And it also allows for the assessment of the credibility of self-reported symptoms, which I'll talk about in a moment. And finally, and I think importantly, it really gives us an indication of whether the individual is prepared for some of the treatments that have been found to be effective for trauma-related conditions, and how that individual is likely to engage with the person providing that treatment and respond to that intervention. And again, we will talk later in this webinar about those aspects or factors within the MMPI-2-RF. So first off, PTSD and trauma-related conditions are easily feigned. The symptoms are entirely subjective. There are very few signs and many symptoms. In other words, we're really relying on the individual patient's self-report. So we really don't know what the content of their dreams are. We don't know without having the individual tell us, and we need to be able to have confidence in our patient's self-report, because we never test for objective signs of post-traumatic stress disorder. For example, increased startle response is criteria E of post-traumatic stress disorder, one of the symptoms, but we don't have any means of objectively testing that, nor would it be ethically advisable to try to startle one of our trauma-exposed patients to see how great that response is relative to other individuals in the population. Actors who are instructed to feign PTSD and go into a clinic often go undetected. There's a study that was conducted several years ago with actors who were feigning PTSD after an automobile accident were undetected by clinicians. So clinicians by themselves, without help of other sources of data, are not able to accurately discern individuals who don't have the condition who are pretending that they do. The symptoms of trauma-related conditions also are widely available and distributed on the internet. So without a great deal of effort, someone can learn about the condition and come in well informed about what symptoms are constitute the disorder and describe those symptoms in a credible fashion. additionally, the stressful life events occur frequently. So many people have experienced symptoms after a stressful life event for a brief period without any significant disruption in activities or functions. So in other words, individuals after an event may have nightmares and intrusive thoughts for a day or two after the event, or a week, but as is the case with the vast majority of individuals, those symptoms dissipate and do not cause much disruption. Finally, symptoms tend to be vague and nonspecific. They occur in other conditions. For example, depression. There's significant overlap between symptoms constituting PTSD and depression. And so individuals can be suffering from a different disorder and again, misattribute some of their symptoms to a particular life event. So it's important to attend to the MMPI-2-RF validity scales to evaluate the credibility of self-report. In other words, is the individual reporting those symptoms accurately and in a manner that is consistent with other people that have the disorder. So how do we know that the MMPI-2-RF is effective in the detection of feigned PTSD symptoms? Well, there are several studies that speak directly to that. In an analog study conducted by Mason and published in 2013, the RF validity scales discriminated college students feigning PTSD from veterans diagnosed with PTSD who passed the Miller Forensic Assessment of Symptom Test, which is a 25-item test that's kind of a mini SIRS, structured interview for reported symptoms. And this, in a way, it's a kind of independent, known group design. Again, college students that's not the highest bar to get over, but the fact of the matter is that the MMPI-2-RF validity scales were effective in identifying those college students who were feigning PTSD. In a study I conducted at the Minneapolis VA with my colleagues, the RF scales distinguish veterans who are seeking service connection for post-traumatic stress disorder, who were instructed either to exaggerate post-traumatic stress disorder or respond accurately as they were, so again, following standard instructions. And we also had a group of mental health professionals. These were my colleagues and some of my interns who were well versed in diagnosis and treatment of PTSD, and we asked them to try to get over on the MMPI-2-RF and avoid detection. And what we found was that the FPR scale with a T-score that was equal to or greater than 90 was the most accurate means of identifying individuals who were feigning PTSD. And it also picked up on the mental health professionals who were actually more able to approximate PTSD. And I just want to, in the next slide, show how the mental health professionals particularly attempted to appear as if they had post-traumatic stress disorder. And the dashed line is the mental health professionals, and then the solid line is the veterans who were applying for service connection for post-traumatic stress disorder. And we can see that professionals, mental health professionals, presented themselves as fairly depressed and anxious, but also quite angry and irritable, whereas that was not the case with the actual patients. So even mental health professionals couldn't quite get all of the symptoms together. So again, using the MMPI-2-RF can give us a good idea about who is accurately presenting their symptoms and who is not. And here's just an example of someone who I evaluated who was claiming to have post-traumatic stress disorder and presented and was administered the MMPI-2-RF within that context. And as you can see, the person very carefully endorsed items. So I like to see this because we know that the infrequency scales can be elevated due to carelessness, and in this case there's no evidence of that, and this person was kind of broadly misrepresenting their condition. This is a complete uninterpretable MMPI-2-RF and suggests that the person is reporting all sorts of symptoms, not only emotional and severe and symptoms associated with severe psychopathology, but also cognitive and somatic symptoms in a non-credible way, and thus we can't make any inferences based on the MMPI-2-RF about that person's current clinical condition. So once we have established that the individual that we're evaluating is responding in an accurate fashion and is engaging in the evaluation process, what do we look for in the MMPI-2-RF in trauma-related conditions? So in other words, what is consistent with the presence of a trauma-related condition as evidenced on the MMPI-2-RF? What RF scale elevations are consistent with these conditions? And then secondly, once we establish that there's probably a trauma-related condition present, what MMPI-2-RF defined factors influence treatment and engagement and outcome? Are there any barriers to care? Do we have to be concerned about timing of interventions? Are people ready to engage in some of the more, effort-intensive interventions or challenging interventions, for example, exposure-based treatment, or do we wait on that? And we'll talk about that a little later. So mean MMPI-2-RF scale differences in trauma-related conditions, what do we see if we have somebody with post-traumatic stress disorder versus someone that does not have a PTSD diagnosis? In male veterans, we see elevations on RC demoralization, RC1, RC2, RC7, RC8, elevated in veterans diagnosed with PTSD who are treatment seekers. So they're treatment seeking. They've already identified themselves as in need of treatment. And in women veterans, we see the similar pattern with RC demoralization, some somatic preoccupation, RC2, RC7, and there was almost a significant elevation in RC8. In a study I conducted in 2011 in National Guard troops who had been deployed for in Iraq in a combat deployment, we evaluated them between about 6 months after they returned, and these are non-treatment seeking National Guard veterans. They had not identified themselves as in need of treatment, and we looked at individuals who screened positive for PTSD on the PCL using fairly conservative cut scores. And we found that elevations on emotional internalizing dysfunction, higher order scale, RC demoralization, RC1, RC4, 7, anxiety, a specific problem scale anxiety, which was the largest effect size, aggression, and NEGI, Sci-5 negative emotionality, were all distinctive for those who screened positive for post-traumatic stress disorder. In another study that Martin Sellbom did in a large sample of injured workers, administered other self-report inventories, including the MMPI-2-RF and symptom inventories for PTSD, looked at latent dimensions of PTSD and examined the ability of the MMPI-2-RF scales to map onto those latent dimensions. And again, there's a great deal of convergence here convergence here. RC demoralization, RC2, RC7, RC8, all predicted the PTSD screen positive for PTSD overall. A specific problem, scale anxiety, was associated with the re-experiencing avoidance and hyperarousal symptom clusters. Anger proneness associated with hyperarousal, and social avoidance and self-doubt were associated with the avoidance clusters. So again, we're seeing that these scales converge not on the PTSD